Great. So we are recording. Hi, everybody, and thank you, and welcome to our Paramedic Chiefs of Canada educational webinar. These sessions are, facilitated and sponsored by the Membership Services Committee of the Paramedic Chiefs of Canada. Kelly Nash is the executive director, and Nikki Little and I are helping facilitate this educational session. We took a little break after COVID because people were webinared out, but we're firing back up again. And the goal is generally, other than perhaps in the middle of the summer months, to have a webinar about every month or month and a half. So keep your eyes out for those. We got a lot of great content coming, and we're super excited about it. Let me get to where I can advance. So Nikki and I are here to help. We've also got other folks from the FirstWatch team, like Mike Tegman and Sarah, with us that will help as we go through it. If you can, feel free to put any questions in chat. We will generally hold questions till the end of this particular session. But if you have a burning desire that you just can't wait at all, stick it in chat or raise your hand. We'll be watching for you and go from there. Love to have the cameras on. If you want to share it, helps when you present to be able to see people's faces and if they're smiling or frowning. So we go from there. Nikki?
Thank you. Thanks, Todd. Welcome, everybody, and thank you for being with us to learn a little bit today. I know it's hard to take time out for yourselves to do that. Today's topic is paramedicine, mental health, and crisis calls in the community, some highlights for leadership. As you well know, there's been an increasing demand for paramedic services to respond to mental health related calls. And for many reasons, it's been becoming critically important to do that with the right care and understanding that a little bit differently. Today, Dr. Polly Ford-Jones will discuss from her current research highlighting what the paramedic leadership needs to know about including sort of an evidence-informed framework for crisis care, along with areas of potential practice change and identifying which mental health related education and training is pertinent for us going forward. I was lucky enough to attend Dr. Polly Ford's presentation for her research at PACE, and I, for one, am looking forward to digging in a little bit deeper today with her work. By way of background, Dr. Polly Ford-Jones is a professor in allied health at Humber Polytechnic in Toronto and an adjunct professor at the University of Toronto in the Paramedicine Collaborative at the Department of Family and Community Medicine. She is a social scientist and interdisciplinary health service researcher with frontline experience in paramedicine, and I welcome Dr. Polly Ford-Jones with us today. Thank you.
Thanks so much. I will just get slides shared here. And is that coming through okay?
Perfectly, thank you.
Excellent. So I'll go ahead and get started. And yeah, absolutely. Burning questions by all means, and otherwise looking forward to some questions at the end there. So thank you so much for having me here today. It's really exciting that this series is up and going, and I really appreciate the opportunity to speak with you. So a bit of an outline of what I'm planning to share with you today. When I say what research, I really appreciate that this is a group of leadership that's striving to have evidence-informed practice and consider how can we put evidence into practice. So I want to briefly share what research I'm referring to and what evidence I'm talking about that's sort of informing the discussion today. And then in terms of background and challenges with sort of the current system in terms of mental health and crisis care in the community, I think this group is likely pretty well versed in a lot of these challenges, but we'll pull out some highlights. And then I'm going to share an evidence-informed framework for crisis care that I hope can guide a good bit of this discussion. And as Nikki mentioned, it was introduced at PACE, but hopefully a little bit more time with it today. And then informed by that framework, I'll plan to share what some of the existing care pathways look like and what some possibilities are and what some real positives are about them. And finally, speaking a bit more to education and ongoing training, where we are, where we can go, and some considerations there, and certainly leaving some good time for discussion and questions. I'm looking forward to that. So I just want to refer to some of this research I'm going to speak to today. And so I'm just going to highlight the studies as opposed to particular papers or anything. There's a number of different reports coming from them. The first being my dissertation research, which was quite exploratory. There wasn't too much happening. There was very little academic and practical attention here at the time. It was field work done in 2017, 2018, and it involved observation in 3 paramedic services in Southern Ontario, as well as interviews with paramedics from 9 or more paramedic services throughout the province, and really drew attention to limited training, limited practice guidelines, also a focus on safety and violence versus de-escalation or communication skill sets, and some highlighted care pathways at the time. And then treat them like a person. This was a study conducted along with Dr. Elizabeth Donnelly from University of Windsor and Karen Ohm from Florida State University. And it was a US-based survey looking at stigma and what we were called there behavioral health emergencies, but stigma in relation to training people had and stigma related to personal experience. And so we'll speak more about that in the training section there. And then de-escalation and crisis training for paramedic students. So this was research done with Craig McCalman and Jennifer Brewer at Humber Polytechnic there, this past spring. And it was a small pilot study, but involved a community partner, Gerstein Crisis Center, where our full cohort of first-year students completed a 2-day crisis intervention and de-escalation training. That was part of their course requirement, and the research was some pre and post brief survey and a couple of interviews as well, highlighting the real value of training, but definitely a need for more than one-off training, and this being something we'll speak to again. And then sort of the largest main study I've been leading and working on in this area with 2 community partners and a large research team that I'll speak to in a moment, was looking at mental health crisis care in Ontario as a whole. So this was not just paramedic services and a range of others. It was including a range of others, but it also certainly included paramedics. So that's where the framework will be coming from. And then just broadly other literature and the work that other folks have been doing in this area that's really contributing to this discussion. And I'm happy to speak more to research specifics, but I think we want to get into the highlights of what are these key implications for leadership and what are some key points of focus today. So we'll begin there. So as far as some background, it's sort of background as to how we're situating paramedic services in this discussion of overall mental health crisis care. We know that crisis response in Canada has typically come from, and typically does from police and paramedic services, and often the emerge department is the only next point of next step or next destination for folks experiencing distress. And then with recognizing challenges with those facts, as well as substantial call volume within paramedic services and impacts on paramedic services, there are new models and new approaches that paramedic services have really been committed to making happen. So the ball is already rolling here, and fortunate to learn from services that have been doing some work in this area, where typically the stated goals seem to be around better meeting people's needs during a mental health crisis, mental health or crisis calls, and addressing the impact on paramedic services, understandably. So again, as far as challenges, I think this is a group of listeners probably pretty well versed in a lot of challenges, but to highlight a few things broadly within the mental health care context and specific to paramedics. My research, along with a plethora of other literature and media, as well as police services from within police services themselves, have acknowledged real concerns with police as a response to crisis or mental health needs for people. And negative outcomes on mental health calls with police response has been extensively documented, including of removal of rights, harm and death on these calls. And we know harmful outcomes and higher levels of adverse police interactions have been identified for people who are identified as having a mental health diagnosis, as well as for racialized people, including Black, Indigenous, people of color, and 2S LGBTQ+ communities, and including those who sit at the intersection of these communities. So the fact that police remain in many communities a regular part of response, and at times almost the only response, is certainly challenging and in a number of cases quite problematic. So these findings are not only international or only in the US, but these are local to Canada too. And so fortunately, while there are definitely challenges and needs for improvements within the paramedic services world in this work, there's different context and different mandate. And so there's real potential here. But at this time, there's often very few options for paramedics on scene and for transport destinations for people with mental health or addictions related needs. And specifically, that is typically the emerge department. which we know to be a really challenging destination for transport or a next step. And the Emerge has many competing demands and largely isn't a space that's designed or set up for sort of supportive care needs related to the mental health and addiction side of things. So we know people frequently attend repeatedly to the Emerge where there's limited ability to meet those needs and often little or no opportunity for follow-up. And then that physical space, that physical destination of care is also a real challenge where it's very sterile. It's focused on security versus making people feel calm and comfortable. And we know that people with mental health needs are more likely to have a security guard with them in Emerge than any kind of mental health support. People are stuck waiting, which increases agitation. There's little supportive care, and people are often cut off from their social connections and supports and wellness tools and coping strategies that usually are helping them to feel well. So this within the constraints of people doing their best within Emerge departments, but constraints within that system. So having those challenges in mind, there's several key pieces I'd like to draw out there and sort of have us keep in mind moving forward. One here being that we need to acknowledge that the current approaches are not actually evidence-informed and really are just the way that things have been done. The fact that police and paramedics respond via 911 to this type of calls is not necessarily about a best practice. It's just the system working as it has, and often filling gaps that exist. And we know that's something we often do, are filling gaps. So with also just some brief policy history mention here, we know that when deinstitutionalization took place, the community mental health care that was promised really was never delivered. So we now encounter these challenges. And also when I'm saying, best practice or evidence informed here, it's not to say that there's one best practice necessarily here. And we really may want to be considering promising practices, which includes multiple perspectives, because this can't be a one size fits all approach. There are different communities and different needs. Another piece to keep in mind going forward is that despite dominant narratives and public perceptions that people experiencing mental health challenges are violent or dangerous, evidence indicates that those experiencing mental health challenges are more often the victims than the perpetrators of violence. And those experiences of violence against those folks are often coming at times of what are supposed to be care interactions. And a number of, again, systematically marginalized groups face higher rates of disproportionately negative interactions with first responders. And these include racialized people, Black, Indigenous communities, 2S LGBTQ+ communities, people with limited economic resources, and those with mental health diagnoses, among others. But with that in mind, we also know that the contexts of care, what are circumstances and contexts in which we're trying to support people or provide care, do have real implications for how escalated or heightened a situation may become. So there's more on that to come. But with some of this in mind in terms of the challenges and what we're bringing forward here, we know that a focus on biomedicine, and that has tended to be where we've come from by nature of what paramedic work has been. So that focus on biomedicine rather than social care and holistic well-being needs and involvement of the criminal justice system when we're considering how to support people's mental health and well-being, our systems have been really focused on medical care. And when I say that, I mean medical care as in medications, hospital-based services, involvement of criminal justice systems. And this has often been overlooking people's more holistic social needs that impact mental health and well-being. So when we have this focus, the emergency response that's supposed to be helpful may actually be the crisis for people, and where de-escalation might have been possible if there were some different circumstances. And just one quote tied into this concept from one paramedic saying that somebody with anxiety isn't somebody who's dangerous necessarily, and they're lumped into the same thing. They're very, very different. We need to understand the difference. Just because somebody takes Zoloft doesn't mean you can't enter their house and they're dangerous, right? Sort of exemplifying that concept. So with these challenges in mind, in the most recent project I've been leading, which was an NSERC College and Community Social Innovation Fund grant funded by CIHR, this is the research team I introduce you to because, again, they deserve the credit for the work they've been doing all on this work, but also just to speak to the interdisciplinary nature of this team, which included and does include paramedicine, emergency telecommunications, dispatch, emergency department nursing, social work, and among others. So the goal was with this interdisciplinary team, as well as with a critical lens, to develop a model of mental health crisis care. And in the Ontario context, try and draw on what's working well, what's the good and innovative work others have been doing, and also learn from what people want and need to see in a system of crisis care. So this framework I'll share was developed by this team, as well as very specifically from our findings from participants who were service users with lived experience, family members of these folks, paramedics, emergency department physicians, nurses, police services, social workers, a range of community-based mental health organizations, including harm reduction and shelters supporting people who are unhoused. So the findings were coming from folks from all of these spaces. And also involved in this research process were our community partners in the project, Lieben Gieber-Michael from Taibu and Dustin Carter from Middlesex London Paramedic Service. So we developed an integrated crisis care framework. And so drawing your attention to the middle here, we recognize that paramedic services and other responders may meet people at any stage of crisis, pre-crisis, where maybe things are not going so well and maybe are escalating, but there's a chance that that does not have to escalate further. Maybe it is that acute point of crisis, or maybe it's post-crisis. Things are improving, doing a little bit better, but what really matters is now what happens next. What's that follow-up look like? And that's going to have real impact for what does happen next for people and how they're doing. And that those stages are fluid. So hopefully speaking to the variety of people that medics within the system may encounter. So we say that looking at the middle there, these 3 stages of crisis are fluid, and individuals may transition between or out of these stages at any time. And a person may move to wellness or recovery from any stage of crisis. And within this framework, there's a need to address all 9 components. So looking to the sort of next ring around there to effectively provide crisis care. And each of these 9 components are necessarily interconnected. You can't have one without the other. And that's the key of this integrated framework. So we have the social determinants of health: collaboration, choice, community engagement, trauma and equity informed, relational care, spaces of care, accessibility, and continuity of care. And then with our attention to the outermost ring there, to implement these components, those 9 components, we need particular things to be in place. And those include human resources, responders who are well and supported, advocacy, stable funding that isn't just sort of a project here and there, but stable funding across longer periods of time, and then training. And these are all considered enablers of this framework. And that having this framework in mind and wanting to engage with it requires ongoing, continuous critical reflection. So it isn't intended to be a real end point here, but a guide in terms of ongoing, continuous critical reflection. And I'm going to speak to some examples within each of these and can speak in more depth to others later. But and I want to highlight here, there's a lot of pieces here, and this framework applies to all crisis response. It's not exclusive to paramedic services. And with that in mind, it's also not paramedic services alone that's aiming to meet all of these needs. So as I'm sharing a little bit about these different components, we can maybe think both where paramedic services can have a strong impact in these areas and ensure these different components are upheld, but also thinking where we can draw on and collaborate with others who are doing this good work in the community. So maybe a good starting point there is looking at the key piece of collaboration, referring to that need for involvement across sectors, professions, services, and drawing on resources and connections for a range of different needs. And a lot of paramedic services are actually already doing this increasingly well, a lot of the time through community paramedicine connections increasingly. But this is one way of really bringing the expertise of others into the care we provide. And it's also how we might be able to better address these 9 components, drawing on those strengths and bridging some of those pieces there. So thinking, are there ways we can collaborate, create collaborative pathways and options to standard paramedic responses for these calls? And then another piece there, community engagement, and again, ensuring that the services are reflective of the communities being served, and we're aiming to meet relatively specific needs and specific community needs where possible. And again, is collaboration a way that we can, one component at least of upholding and supporting community engagement there. And then I would like to add the relational care piece. So paramedics often say on these calls, well, I didn't do anything on a mental health call. And what might seem like nothing can be everything. And that relational care piece is your ways of interacting, an emphasis on flexibility, empathy, dignity, and recognizing that the way we're speaking, our body language, our approach to communication make a huge difference on calls. And we had many paramedics, when they were talking about, what they'd want to see differently or what they want to see on these calls, say just treat them like a person, not like a call, not like a diagnosis, not like a problem, but treat them like a person who's in need of support. And we know a lot of paramedics naturally do this and have some great skill sets in this, but we also do need to consider how we need to prioritize education and training here. So more to come on that. And thinking of the trauma and equity informed piece, this means recognizing that people come to an interaction with previous trauma and previous history, both the person in distress as well as responders thus coming to the call. But when we first meet someone, they may seem really upset or they might seem defensive. But in that very moment, how we're responding has the ability to shape and change that interaction. If we're aware that that response isn't about us personally, it may shape quite a different response in that interaction. And we also, with that trauma and equity informed lens, have to have understanding that many communities do have distrust in 911 services and in the health system due to colonialism and historical or ongoing trauma. So how we can incorporate that into our crisis responses and awareness. And thinking of spaces of care, we'll speak more to some of this, but how can we maybe create new pathways to different pathways of care, and where we've been limited in our options for next steps there. So the spaces of care might have potential for looking different than they have. And then just a last one to highlight, and again, these aren't to prioritize any of these, but rather just to offer some specific examples to paramedicine. But the component of choice, and these might be big or small choices, and small choices on scene we know can look like offering someone like, what would you like to bring along with you, and taking the time to offer and ask that. How would you like to go to the ambulance? Is it walking? Is it a stretcher? What would you like to do in that way? But it could also be other bigger things. And could we be in a position of asking and offering choice in what kind of care and support somebody needs in that moment? So it's not only a style of approaching a situation, but it also has to be supported by those systems pieces as well. We need to have some options to be able to offer choices. So those are a few highlight examples, and I'm certainly happy to speak to more of those components upcoming. And again, emphasizing that this isn't limited to the one sector, but rather these integrated components. So also highlighting that this isn't a logistical or linear guide on how to sort of develop a crisis response team. It's not that intent, but rather that these components are the foundational and essential components of an integrated crisis care framework. With application at certainly a systems level, as well as relevance to mental health services, more inclusive and sensitive to the needs of specific communities and the ways in which they might be deployed there. So we're thinking if we have existing approaches that we're looking to potentially improve upon, or at least reflect upon, then this framework offers some guidance there. And then for different services that may be considering new approaches or development of new approaches, the hope that this can offer some guidance of what are some of those foundational or key components that ought to be there. And then there'll be some pieces both at systems levels and individual care provider levels. So what I'm looking to speak to next, when we're thinking of some of the systems level change, it might be in those actual care pathways and options and what possibilities there are there. And then when we're thinking of the individual care provider and how this framework might relate, we might be thinking more to some education and ongoing training and sort of bridging those two pieces. So I'll share some of the different approaches that paramedic services we found have already in place, and that may be some of you folks here that have great experience with this. And in some of these examples, it may be only one or two services, but maybe more. But the point is that these do exist. These pathways and possibilities have been put in place. And I'm also not wanting to suggest that these are all separate options and only one is needed. In fact, some regions have got several of these in place, and really options are the goal. So one thing I want to point out here is that I want to name two things as far as what you won't see so much on this list, is that you'll notice that these are not speaking to police-led initiatives. I mentioned earlier that it's been strong and consistent messaging from participants with lived experience that where there is no active violence, police response is not what should be the goal here. And police response, when not warranted for active violence, in fact, has real potential to escalate a situation and may actually become the crisis for somebody based on their previous experience. And that message has also come from our participants within policing, that's not the focus of the work they're designed to do. So I'll be sort of explicit about that piece. And you'll also notice the other thing is that this is not a list of primarily psychiatry centered or hospital-based services either. And while that might be the right support for some folks, findings that do include the perspectives of people with lived experience and sort of a critical mental health lens recognize that there's a need for care and supports outside of hospital and psychiatry too. So more on that to come. And so the first example here being having alternate destinations. So having acknowledged the challenges with the emerge department, the idea was to have what could be other options there. So things like a crisis center, having a 24 hours crisis center that's based in social services and supports where people can be connected to things that'll meet social determinants of health related needs, other counseling, ongoing support, rather than a stop in hospital and the lack of follow-up. So that being that sort of crisis center alternate destination, as well as stabilization and connection centers that might be supporting people with addictions and substance use needs, and some targeted programs that are, for example, where folks who are already connected to the shelter system might be then, as paramedics meet those folks, have the possibility of bringing them directly back to a specific social service there. And so that being another alternate destination as opposed to going to emerge first. So those are some of the examples that have come up. And then we know that there are a number of different paramedic co-response teams, and typically these are targeted with the intent of responding to the calls that are mental health or addictions related. So that might be paramedic with a crisis worker or a harm reduction worker or social worker or a nurse. And then crisis lines, we know there's many crisis lines that exist, but some services have had in place crisis lines that in fact the paramedics can, with the consent and involvement of the person on scene, call along with that person where there's some further possibilities there, and perhaps that person doesn't want or need to go to the hospital at all, and that crisis line and what those follow-up pieces of connection can be then offer some other opportunity. Finally, community paramedicine, which has been increasingly also had focus on again mental health and substance use related needs, where there's possibility for follow-up, further connection to resources, some preventive pieces, and the good work that's been happening around social connection for people who are isolated. We know those significant impacts on people's well-being. And that's a number of different iterations in different spaces there. And then this last piece around crisis response teams, I thought this isn't a specific to paramedic services, but it's a potential for connection, where, as for example, in Toronto, where it has been, or was a pilot study of having non-police, and in fact, it was not paramedic led either, but non-police involved crisis teams were piloted, determined to be really effective and have very, very positive impacts on the calls that were happening and reducing emerge visits and other 911 service involvement. And it's now Toronto Community Crisis Service. So it's an established service, no longer a pilot, and it's sort of effectively the fourth emergency service in Toronto where that service can be contacted directly even instead of 911 or can be connected to through 911. So I bring that up, and there's also one that's recently launched in Ottawa, and I think others in the works. Because then those are potentially services paramedics can connect with on scene as well. And those might be really well-resourced teams that will be a support in those pathways and possibilities. So I just want to draw a little bit of attention as to why these pathways matter, and sort of why it's important that services have established these options. We know that the emerge department's always there, and if that is a genuine choice for the folks in need of support, that is there. But we also want to have in mind that for many, or almost for most, it's not an option, but rather a forced choice. It's you can't stay here, you're not doing okay, and you have to go somewhere, and that's the only place we can offer. And it may almost be a penalty for calling. And so somebody needs help, but that's the only possibility. We want to look to the positives of what these alternate pathways can be, where they're offering non-medical supports, and that meaning that a place that can provide care extending beyond medical care, that has the potential to meet patients' sort of social and material needs, as well as appropriate follow-up and prevention, and continuing to address people's social determinants of health there. And we know that one key challenge that's existed within emergency responses for mental health care, and generally a lot of aspects of the mental health system, is that people with mental health needs experience a great deal of coercion and often have very little or no say in what their needs are, what their preferences are for the types of support they'd like to receive. But what we also know, and there's evidence in literature to support this, is that the role of personal agency and autonomy in moving somebody towards recovery is significant. And having people involved in self-determination, involved in choices about their care, even if they're smaller choices, and what they need is really significant on a longer term scale in terms of how people do and what recovery might look like for them. And being able to offer choice and listen to a person's needs is a significant component of that relational care piece. And so having that where care is not just a directive and transactional piece, but these different possibilities give choice and options both to the person who's in distress as well as to the paramedic providing care. So rather than someone having called 911 realizing they're all out of options, but actually the response shows up and they realize there are now options to be offered to meet their needs. So to be able to provide this kind of relational care with options, paramedics do need for those options to exist. And also be equipped with the skills to support that relational care approach. And also just being able to connect people to a setting that's then already linked to clear follow-up options is particularly important in trying to be preventive as well. So having shared some of those care options and positive examples of options and approaches that have been employed by some paramedic services and their community partnerships, I'll share now some of the highlights around what we've learned about education and ongoing training of paramedics for mental health crisis care responses. So from the initial exploratory study that I did in 2017, 2018, right through to our most recent study in responding to surveys or in interviews, paramedics have consistently been calling for more training, more education to better support their response to mental health related calls. So one paramedic said, it would be nice to have better protocols and training. Another said, I wish we had more education. I don't feel prepared to deal with many of the situations I end up in. What currently is done doesn't work. We do our best, but we aren't trained, and I fear I may do more harm than good in some situations. We definitely need more training and resources on interacting and communication with different communities and how to best serve their needs. And then sort of a final bit of a summary type of quote here. One medic said, we try our best, but the only training we have is our own learned experiences in our own lives or through dealing with acute mental health calls in our career. So if we have been doing it wrong, then we continue to do it wrong. Or we learn from our mistakes, but then there was a person on the other end of that mistake. So this is a small sample of the quotes from the most recent research, but it is really, really representative of what we've been hearing over the years in research here. And also listening to these quotes and drawing from what the paramedics have shared here, referring to feeling unprepared to end up in a particular situation, concern about having actually done harm in situations and their unease with this. As we're considering in paramedicine in general, where we can continue to better support medics, to prepare them both to attend to calls, but also support their well-being, this is offering one distinct place, both for medics and for improvement within community care there. So we have identified a clear need for further education and training for these calls. That's been very clear. I also know that speaking to a greater need for preparation through college education isn't necessarily in the domain of this group, although I will say that your advocacy for the importance of strong foundational paramedic education is absolutely valuable. And so I want to mention it both for that you to seek your support in that advocacy, to support paramedics' strong foundational education, to support them for a long and healthy career. But I also want to mention it because that foundational piece is really important, and I don't want to suggest that all responsibility falls to services. But at the same time, we do know that there's a need for ongoing, continuing medical education, and this is one means of reaching out to those who are already on the road. And so this said, at the risk of starting with a negative, I think this piece is important to highlight, and that's to say that not just any training is the answer here. So some important pieces that we found. Once study, the study of on behavioral health emergencies, and looking at mental health calls and stigma, the finding was that those who had behavioral health emergency content in their most recent CME reported higher levels of stigma. So that's to say, paramedics said, yes, I did have content related to behavioral health emergencies in my previous CME, but they actually measured higher on levels of stigma. So it begs the question, what was the content of those CMEs? Was it about restraint and sedation? Was it about paramedic safety versus the safety of the person that they're caring for? Was it about diagnostic categories and diagnosis, which is not something that is our scope or skill set? And I acknowledge that I don't have the answers to that. These were different medics from different services and different regions. But we do know a bit about what tends to be in paramedic training and what has tended to be in paramedic training around this. And that I don't say this to ask you to not do training. That's definitely not it. But it is to use caution when we're thinking that any mental health or crisis-related training is better than nothing. Along with this, we know there's other literature that indicates that a biomedical view of mental health, and when I say that biomedical bit, I'm meaning thinking illness, disorder, chemical imbalances, intervention that's needed from physicians, again, categories of diagnosis, having that view and that training around mental health may actually negatively affect stigma among healthcare providers, and has been found to. And so historically, at least, we know we tend to be pretty biomedically oriented, and we've had lots of increasing talk about some shifts away from that. So we do have to give really careful thought to what preparation we do give to paramedics. So while I can speak more distinctly to the Ontario context, in speaking to folks outside of Ontario, it does seem to hold quite consistent and across the board that the only guideline or protocols we have related to crisis or mental health relate typically to safety, restraint, sedation, and fear for harm coming to medics. And there's real concern that having focus only on these places is not building skills, building competence, and appropriate confidence in good communication skills, strong interpersonal skills, strong de-escalation techniques, situational awareness, and awareness of how to work from a trauma-informed and equity-oriented lens. And these pieces have been missing, and I think are still missing in quite a lot of what is being proposed as training. So where you're in the position of determining what training your medics will or will not have, I do want to offer some evidence-informed, distinct pieces for consideration here. I know it's immensely costly for you to choose to carry out training for your medics. It's a huge time and money investment. And so I want to provide some support for what might help with decisions about what will or will not be valuable in this domain, and potentially what could be harmful both to communities or medics themselves. And these questions are oriented to the community and evidence-informed framework I shared, as well as to some other literature in this area. So here are some key questions I would consider. So first, who is developing and delivering the training? So we've already discussed evidence that police responses and police approaches to these calls have been and are particularly problematic. But at times we're carrying out training of our paramedics by police or by previous police. So we have acknowledged that need to move away from those types of responses and approaches, and need to maybe have that in mind when we're considering who's developing and delivering the training. Or is it in fact a community-based organization that has expertise in community needs, in mental health, in crisis care, and effective approaches to de-escalation and supportive communication, and to appropriately and safely meeting the needs of people in distress? So those would be some key pieces I would suggest having in mind related to the who is developing and delivering that training. And then linked to this, is this training purely focused on risk mitigation and safety? Does it risk painting the picture that all people with mental health needs are violent and dangerous? Does it risk making responders more heightened and agitated themselves when responding to these calls? Or is it training that builds understanding, builds communication skills, compassion, relatability, and a human approach? And so further, also, does it create understanding that how we respond in those moments and the resources and supports we have available for these calls has really big implication on how that call goes? And does it equip us with more skills? So following that, in what ways will it further develop paramedic skill sets in relational care, in communication, in de-escalation, or navigating interactions with a person in crisis or distress? Also, has the organization or the training itself had input or direction, or maybe is led actually by people with lived experience of crisis or mental health service use, knowing that that may very distinctly shape the way that the training goes and the orientation of how we might be able to move forward in supporting people. Is the training and the organization itself trauma and equity informed? And if not trauma and equity informed, we're looking at a real gap in how medics are being prepared to respond to these calls. Again, and finally linked to that, then in what ways could this training make inequities in care better or worse? So this is not one magic bullet or one training that I'm saying should happen, but rather while you're considering what training is out there being offered, or maybe you're considering who you might want to collaborate with to have training developed here. This, I hope, provides some evidence-informed questions to ask and consider. And I'd certainly be happy to connect and discuss further as you're looking at these possibilities down the road outside of this presentation. And I know we're covering a vast geographical area here, so options will look different. But there really are some superb community-based organizations that do excellent work in this area. These aren't sort of businesses looking to make money off of this in that way. These are often nonprofits who are really committed to doing this work, are experts in this work, and are trying to make real improvement in these spaces. So we'd be fortunate to draw on those services and that type of training. So three key takeaways that I'd like to summarize here is that continuing to build on and develop collaborations with community-based organizations that are doing this work and doing it really well. Again, that's been underway with a lot of paramedic services in different ways, but continuing to build on that and develop these collaborations will really support better carrying out this integrated model of crisis care, this integrated approach, and recognizing that paramedics can't do this alone, and we do need that support appropriately so. And then how can we prioritize education, strong foundational education and ongoing training? And as leadership, again, I ask for your strong advocacy and support for that strong foundational education for paramedic students to prepare paramedics for long, well-prepared and healthy careers. And also, can we prioritize ongoing training in this area? And when we are, can we carefully consider what that looks like using the reflective questions from that previous slide there? And along with that training, we know we need the systems pieces to make things work. So for other possible systems changes, what alternate care pathways can we offer? What would work within the communities that we're serving in those spaces? So we aren't just sticking with the defaults that we know have been problematic, but we can consider learning from these positive options that have been moving forward. And I've got, from the most recent study, I've got a report that's coming out in the next week or two, ideally. I'll share a website at the end where you'd be able to find this. And there's expansion on this and a list of key recommendations. So now I'd be really happy to hear any thoughts or questions, at this point.
Great, that was fabulous. Looks like Tony Stretch has raised his hand. You should be able to unmute yourself and ask your question.
Hello, my name is Tony. I'm out of Alberta and I work at the ASC committee. As I've seen in a couple of the comments, we're trying to reform our EMS system here in Alberta. I guess my question is what kind of focus? And I actually started to type a chat, so maybe I'll just read it. About 20% or about 8 million of Canadians live in a rural or remote community where the development of some of these programs and pathways of care is difficult to support. What kind of focus was placed on this demographic during your research, and do you have any data that you can share?
Yeah, I appreciate that question. Absolutely. So there were a number of different services that participate that expressed exactly the concerns and challenges that you're mentioning there, be it geographical spread, be it who our populations are and different people we're needing to meet in different ways. And I think that I'll preface this by saying I don't have any one answer or any one piece of data that sort of solves all of that, but acknowledge that there are services that have been doing work in these different ways. So such as through some community paramedicine options, whether that's been sort of an anchor of the community paramedics have the connections to further support and resources, and they can be more readily drawn on than, again, connecting to a specific crisis center might be not possible within a huge geographical region. So that's sort of an example I could refer to that I know is been happening and increasingly happening, and that I can speak to some of the services that have shared that they've been both eager and willing to connect with other services who are trying to do this work. So they've already started it, and they say, we'd love to be talking and sharing ideas, and how do we move forward. So I think that there's hopefully some lessons learned that can come from that. That's just a sort of a one example that I keep in mind, as well as, so some organizations sort of identified that they know of particular organizations within communities within these rural or remote areas that are great options, but current policy mandate has them having to go to an emerge first, and then they might connect back to those. So I'll say that I'm acknowledging as a challenge, but what ways can we overcome those barriers so we really can more directly connect people to the things that do exist, even within some of these more rural or remote communities. So not a.
And I guess that's my question. Yeah, thank you.
Looks like we have a hand from John Reaches, and then Mike, if you're watching the chat, maybe you can watch for people that have just posted things in chat and can share them for us after John.
Got it.
Great, thank you, and thank you so much for the presentation today. Very informative and really exciting to see this level of detailed research occurring. My question: I work with an amazing team in southwestern Ontario. At a regional paramedic service, and like us, a number of services in Ontario, as you probably well know, are rolling out things like EVAP training and things like that to their paramedic teams. I'm just wondering what your comment or what your advice might be about EVAP training specifically, and how it might intersect with all of this work. Thank you.
Yeah, so I appreciate the question, and I'll preface it by saying that I have not taken EVAP training myself, and I'm not involved in that research. What I would probably primarily answer is I'd say my answer would be to refer back to those questions around what training is happening and diving into those answers. And if folks are looking to engage with any training, looking at those pieces of, is it, and I'm going to just jump back there because it's just to highlight that. Oh, sorry, those pieces there. Gone too far, but the pieces around who is providing that training, what is the point of focus there? Is it going to be building skill sets that are supportive and going to work towards de-escalation? Has the organization or training itself had input or direction from people with lived experience of crisis or mental health service use? Is it trauma and equity informed, and in what ways could it make inequities in care better or worse? So I'm not trying to dodge your question, other than to say that this would be my overarching guideline and suggestion for any training throughout the vast geographies that might be happening here, and really critically reflecting on that. And I'd certainly be happy to speak about more specifics if there are questions sort of at another time too.
Okay, thanks so much. Appreciate it.
So there are a couple of things in the chat. There's a lot of great resources and pull quotes from your talk that have been posted. There is one question from David Brown around clarifying an acronym, which I think John may have answered. David, can you just unmute and say which acronym you were curious about?
Yeah, it was the EVAP. I actually have a totally separate question. I just wasn't sure what people are talking about there. So,
okay, what's your separate question then?
Yeah, thanks. So amazing presentation. I really appreciate your time today. I work in Vancouver, and so one of the things we work with right now is that we have a very fragmented landscape with a lot of other folks working in this mental health response space, between sort of straight up policing, police integrated teams, police de-integrated teams, to totally community response based. And so as we're planning out our structure, we're really trying to make sure that we're providing new value within there and fitting in. And so I'm wondering if you have any thoughts on where sort of the paramedic integrated model provides something unique or different to fit into this already fairly busy space.
That's a great question, and probably one to which there are a number of different answers. And I know folks who are, such as yourself, who are already working in these spaces do know so many of these organizations and quite well, but other than from what I've learned from the services that have begun some of these different paramedic-led or integrated models, is really diving into those collaborations and connections, learning what those gaps might be, or if it's not gaps, in fact, because they, as you said, there's a lot of things happening, what would be some most ideal places where there's room for connection, where there's room for that, whether is it paramedics being able to do a warm transfer, is it being able to connect people to directly to those specific spaces of care. Are there possibilities for partnership there where you're able to leverage the great work that's happening? And so I think that it would be certainly community dependent, but hearing both the knowledge from your paramedic services side of where you might be seeing things not flowing as smoothly as you'd like to see or going as well, and then the input from the community side saying, yeah, we'd be able to meet this need, we'd be able to make this connection, or let's see how we can move that forward, might be some of my initial thoughts around that.
We've got a question from Ray Bell about, it says, recently built a learning management system and are wanting to put up educational materials for our registrants, wondering if online training is sufficient for this type of education, as we would currently only have an online platform to deliver. Also would welcome any content and material.
Super. I think that my response would be, and just from hearing from the different medics, some saying, yeah, would love to have more online training. That can certainly be a piece of it, right? I would be hesitant to say that would be the only piece, and I understand timing and resources, budgets, et cetera, might mean different things can roll out at different times. But I think that could be a really valuable piece of it. And it might be one piece, and then until or when you're then able to maybe have some in-person work happening in that way. So there's certainly been people who are keen for more online training. In terms of resources, I'm going to share a website at the end that we're hoping to have. It's a free and publicly available website that will have a small module, and not to suggest it's comprehensive on it, but a small module that will be available for training sometime in the next several months too. So I'd be happy to share that as just one resource, and could chat about some others too.
That sounds good. We've got one more from the chat, and then somebody else has got their hand up there. So says, thanks for the information. I assume you're talking about a truly laddered education from EMR to CCP. This work has been going on in a number of provinces for years now.
Yeah, I appreciate that. And I think that I appreciate that laddered approach piece, and that really building those foundations. So if we want to start from as far to the beginning as we can, really asking for that advocacy and encouragement of strong foundational education from that student training right through to then considering how we can support ongoing training. So it's not one-off things, but rather continuing to build and support ongoing with that.
Sounds good. And it looks like Tyne's got a question.
And then really quick, before you answer that, Polly, would you mind going to your next slide so people can see the contact information as we finish that out?
For sure.
Thank you. Thank you, ma'am.
Hi, Polly. Thanks for your presentation. Just incredibly robustly informed and inspiring as always. Just a comment first. I just always appreciate how explicit you are in naming the systems and structures and barriers and challenges that, you know, are the nuance and the complexities in these issues. And it's just so important to not glance over those, because as we try to make change here, those are the big boulders ahead of us. But in that vein, I am very interested in a leadership role in, you know, dismantling and rolling aside and pushing aside those boulders. And so I'm curious if your project, or if in your research you've come across any guidance in the lane of implementation and change management. You know, in particular, one of the hurdles that just seems to be so set in stone in our services is the relationships and the biases of assumptions of police as helping, and even so far as our dispatch and automatically launching and sending police to these scenes, and how we automatically are at an escalated, just trying to change, manage, shifting perspectives to not always assume that that's a need that's going to benefit, and how crews can feel safe in engaging in these calls without those normed ways of approaching.
Thanks so much for that, Tyne. And I know you similarly ask a robust and complex question for sure. And I'll try and touch on a couple of pieces with that. I think maybe what I'd say, I don't have specific pieces of what change management looks like, but what seems to have been the case is a lot of shifts from multiple places. So yes, there's been media attention to this. There's been changes in funding. There's been pushes of more things happening from different spaces. So again, I'm speaking to areas where there have been crisis teams that are neither police nor paramedics launched. And it's just the happening of that has seemed to create some shifts just in what's available. And then we see what's possible, and we see, oh, look, when the communities organization is doing something one way, things are really working well. Actually, there's some great data. And while I think that qualitative data is super important, and I think we miss a lot without it, I know that the numbers also help solidify some of those arguments. So there are some neat reports that I would be happy to connect on that are from some of those areas that might be like supportive of some of those discussions. And I think that the shifts in understanding and shifts in what possibilities could be maybe are largely coming when we actually see what those other options are. And so that there will inevitably be growing pains with what changes look like, and maybe tough uptake to start with. But then gradually there's more and more shift there. And just, you mentioned that, how are we ensuring that our medics are feeling safe engaging? And that's of course really important. We want that, and directing to, again, the crisis center that does a lot of training, the Gerstein Crisis Center, the folks there, they're speaking to, building understandings of what conditions can make a situation more safe, and then equipping people with the skills that they know and plans and systems to, rather than a one-way approach of any sort, but a well-rounded, what are these conditions of care? What are these options we can create for ourselves and for the people in distress? And bring things down a fair bit in some of those different ways with that type of both training and systems options.
Yeah, no, that's excellent. It really is bringing it back to that, using the strengths-based approach in the implementation of looking to where the work is being done and what's working, and amplifying that and learning along. Thanks, Polly.
Thanks, Time.
And our last question in the chat actually comes from Nikki. So Nikki, if you want to unmute and ask your question, and maybe you and Todd can move this to a wrap up.
Sure. Actually, I was midway typing it, and then Tyne kind of touched on it, so it's fine. But I was just sort of thinking about whether or not you knew of any services that are sort of trying to predict sort of a 911 response, or an alternate response from the 911 stage. We find that, not just for assuming mental health crisis, but just even check well-being, sometimes we're arriving and disrupting the person, and often escalating it with police and paramedics arrival. So I'm just curious about what other people are doing, but you kind of touched on that a little bit, I think.
Yeah, just to add there, as far as alternate response, there's on the website there's also a link to a paper that was done with Middlesex London Paramedic Service, who've done a ton of work in this area and are due all the credit for that work, but may offer some of the means of how that went about, and not to suggest it's a fast process, but that piece. And then, I think the crisis response teams also recognize better understanding how these things can fit into systems and how we can work well. And I think also, when I keep saying education and ongoing training, I think that's also interprofessional and cross professions training as well, building up better understanding of what different resources can do, and how we can draw on each other rather than be trying to figure that out on scene, and know a little bit better ahead of time, maybe.
Awesome. Thank you. And thanks for all the great questions. Todd, you want to wrap it up?
Awesome. Yep. Thanks very much. And that was truly amazing. This recording will be available from the Paramedic Chiefs of Canada webinars page until our next webinar, which, as you can see here, will be February 6th. I encourage you to save the date and time. At that point, it will go back into the members only section. So enjoy it while you can. And I thought it was just truly fabulous. You can also sign up on our website at firstwatch.net/HI for health intelligence, and we'll keep you posted of these, as well as you can get the emails from Paramedic Chiefs of Canada. I will say that if you're not a member of the Paramedic Chiefs of Canada, or your organization isn't, I strongly recommend it. It's a great group of folks. If you're inclined to improve your networking as in your career, to help out with the committees, and being part of that is a big part of the success of the whole industry. Feel free to reach out to Nikki or I or me to talk about that. And thanks everybody for your work. Dr. Ford Jones, that was really good stuff. My request for you might be to put, if you haven't already, to put a couple paragraphs behind each of those questions that you suggest we ask, to sort of after the fact allow people to sort of look at it, at least from your perspective of what you're looking for, in who's training and some of those questions. I think it's not necessarily like you're telling people what to do, but hearing it makes it easy to understand. Reading it a month later might be hard, but it was really nice work. I'm very, very impressed. Thanks, Nikki. Thanks, Kelly. Thanks, everybody, for your questions. Thanks, Mike, and Sarah, and Jenny, and everybody who made it all possible. We appreciate you all very much, and look forward to, hope you have a happy holidays, and look forward to seeing you in February for the next session.
Thanks, FirstWatch family, and thanks, PCC.
Thanks so much.
Bye-bye.
Thanks, everybody.